So I'm excited about the future. And just because greater than 95% of myeloma patients respond to initial treatment does not mean we're done. And myeloma patients still relapse, and I consider that a personal failure. So we need to do better. So my big focus here is about immunotherapy, monoclonal antibodies, CAR T cells, etc. I am going to talk about naked antibodies and how they stimulate the immune system to attack your myeloma. I'm going to talk about antibody-drug conjugates, which I think are really exciting and people are not talking about nearly enough. I'm going to talk about checkpoint inhibitors, which has been all over the news, and of course, CAR T cells. And I am very, very, very excited about CAR T cells and these antibody-drug conjugates. Let's take a quick look at what's available, what tools are in the tool shed. If you start on the top left-hand corner, it really started with steroids. Dexamethasone or Decadron is the drug we love to hate. I specifically love to hate it. Proteasome inhibitors, Vortet, Velcade, Kyprolis, and Laro, all of them are available. They are one of the few drugs where dose is equivalent to effect. The higher the dose, the more effective the drug. Dexamethasone also, the higher the dose, the more effective, but there is a clear level at which the effectiveness will lead to patient mortality. So there is, at best, so-called a sweet spot, and honestly, the sweet spot in my view is not to use these drugs. IMiDs do not have such a dose-response curve. The higher the dose of IMiD, it's not clear that that's any more effective, and it's certainly more toxic. Revlimid and Pomalyst are the ones that are most commonly used in the United States. Deacetylase inhibitors, Feradac is FDA approved. I have used it a very few times after its FDA approval. I struggle to use this in combination with other drugs at an effective dose where the patient does not hate me. Sometimes we start off on a tough plot. All right, Empliciti or elotuzumab is a naked monoclonal antibody. It has no single agent activity. And I also struggle to find patients where I can use this drug effectively. Daratumumab has single agent activity, and I say single agent, of course, in myeloma. Single agent means that our companion dexamethasone or Decadron is always trailing along. So it's true that these drugs, elotuzumab and daratumumab, have been studied in combination with dexamethasone. And daratumumab is also FDA approved alone and in combination. So these first six on the left-hand side are the past. This is what we have now, and this is what I'd like to see go away. I don't think any one of these are the stepping stones to a cure. I don't think any one of these I want to see us using 10 years from now. I would like us to move exclusively to the right-hand side of the page, because I think this is the future. And I think that antibody drug conjugates, such as those that target BCMA and SLAM F6, are interesting drugs. They make something old new again. They target a myeloma cell, and then they bring with it a poison payload. These may not be perfect, but some of their responses seen in extensively pretreated patients signify that these are going to be very powerful treatments going forward. I used to not think this, but I am more convinced now with current data that these will be a component of future treatment. And as the other Craig has said, they are treatment agnostic, meaning they find the myeloma cells based on the surface and not what's inside. And what's inside the myeloma cell is so often what's so difficult to treat in patients with high risk or more chemotherapy resilient myeloma. The next one are chimeric receptor T cells, CAR T cells. The ones that have been given to patients so far, at least A grouping, target CD19, B-cell maturation antigen, and CD138. And then ultimately oncolytic viruses, who knows whether they have a place, but they're awful cool. And I really love things that are cool, and I really love things that are different, and find a way to get into all cancer cells and are agnostic to prior treatment exposure. That makes me so excited. And so this is really the area that I want to talk about. We'll start with the monoclonal antibodies. I'd like to mention, first and foremost, that a number of these slides were donated by the good Dr. Cole to my effort here, and I thank you so very much. Any slide that looks really nice is from Dr. Cole. So, and I took out some of the Star Wars references. So, anyway, so myeloma cells is a big myeloma cell. These are some of the well-known proteins on the cell surface: CD38, SLAM, F7, CD40, CD138. All of these have targets available, and actually one more, I'm sorry, and BCMA at the bottom through primarily CAR T cells, but as well as antibody drug conjugates. The ones that are used most commonly now and are FDA approved are elotuzumab, and on the right, Daratumumab, but other antibodies have been tested. So Daratumumab is a CD38 antibody. It's given intravenously and is always given in combination, either with dexamethasone or with Revlimid, Velcade, and Pomalyst. It has been very effective, and the ones that are in green are currently FDA approved, and the one in whatever color that is with Pomalyst and dexamethasone is not FDA approved, but we've certainly given that quite a ton at Ohio State and other centers. The data supporting daratumumab usage in combination with Revlimid and dexamethasone is based on two very large phase 3 trials. One is CASTOR, and these patients could not be refractory to Velcade, although I can't spell, and these patients had at least one prior regimen, and they most often had many more prior regimens that these patients have been exposed to. So this is about 500 patients, and half of them got daratumumab, Velcade, dexamethasone, and half of them just got Velcade and dexamethasone. Note, they all had to be no evidence of Velcade resistance in the past. So, not surprisingly, when Velcade is given twice weekly at full dose, about 63% of patients responded, and when daratumumab was added, 84% of patients responded. So that's clearly better. The Pollux trial is another 570 patient trial. These were patients who had only 1 to 3 prior lines of myeloma treatment, and they got daratumumab in combination with Revlimid, dexamethasone, or Rev-Dex alone. 93%, I think, and 76%. So a higher response rate with daratumumab in combination to Revlimid, dexamethasone. More of those patients went into complete remission. More of those patients were MRD negative after a number of cycles of treatment. This really is one of our most common regimens to be used at Ohio State in second-line therapy, in daratumumab, Revlimid, and dexamethasone. Daratumumab is administered in a complicated way. It's given intraweekly for 8 weeks, every other week for 8 infusions, every month until it stops working. There are a number of possible side effects. One of them is patient anger. Patient anger is a complicated thing. The first infusion is long, and that's why patients are upset about it. They have to show up early to the infusion center. It's a whole, basically, 8 hours worth of sitting around for very little to happen. The key components to decrease your risk of an infusion reaction, which is incredibly common in the first infusion, is to have some dexamethasone on board. So give dexamethasone pre-medication, and take some Singulair prior to the infusion. This was not known when it was originally given to patients, and these seem to be the two most important pre-medications to decrease side effects with that first infusion. If you can last during that first infusion, where I suggest bring a book, do whatever, the key things that you need is that the next infusion only lasts about 4 hours. That's still too darn long, still unacceptable. I agree with you completely. And we're working, Janssen's working to do a subcutaneous formulation so it's less of a burden to patients. The third infusion and thereafter at OSU, we're able to give it over 90 minutes, and that is our standard. That data is on its way, but this is, at least 90 minutes is still too long, but it beats 8 hours. And I have found that in our patients treated with daratumumab, fatigue and pancytopenia, or low counts, low white cells, red cells, platelets, occur primarily in the patients where it doesn't work. So not only do you waste your time at our center if it doesn't work, but you have side effects. Yeah. So this is what we see primarily. In general, daratumumab, as administered, is relatively well tolerated. Elotuzumab. Elotuzumab is targeting an essential protein on the cell surface. Again, there's animation, courtesy of Dr. Coe, what is thought to happen is that the immune system attacks the myeloma cell once the elotuzumab attaches onto it. And it does not work when elotuzumab is given with dexamethasone. It causes really no anti-myeloma activity. Hence, it was tested, elotuzumab in combination with Revlimid and dexamethasone, and compared to Revlimid and dexamethasone alone, showed a higher response rate and a longer progression-free survival, meaning it kept patients' myeloma controlled longer than those patients on Revlimid and dexamethasone alone. And this is primarily in patients who are Revlimid, known to be, thought to be Revlimid responsive. This is administered every week for the first 2 cycles and every 2 weeks thereafter. There are a number of side effects, and usually if the first infusion goes fine, the patients that we have had on a clinical trial using elotuzumab have had very few side effects thereafter. Patients have a complicated dexamethasone dosing strategy prior to each elotuzumab infusion, and they take standard weekly dose dexamethasone with Revlimid. Now comes the confession. I've never used this drug outside of a clinical trial, and I don't plan to. As it stands, elotuzumab seems to be very efficacious, and hence I have not found a patient where elotuzumab would significantly improve my treatment algorithm. It is thought that patients who are not responding, but slowly not responding to Revlimid maintenance might be a great subset of patients to target by adding elotuzumab to the regimen, and I certainly think that that may be the case. CAR T cells, this is a view of a cancer cell and then a toxic T cell right next to it, killing it. The idea between chimeric antigen receptor T cells is very simple. You start with the patient and you take some of their T cells. Basically, you take them right out of an IV. You really just need about 60 cc's, but sometimes more is taken out. These T cells are then infected. They're infected with a very specific virus which injects some DNA into these T cells. This is a stressful process for these T cells. And what this forces these T cells to do is to express on their surface a protein which forces them to target, ideally, myeloma cells. Now you can make them express targets for BCMA, CD138, SLAM7, whatever you want. And ultimately, these genetically modified T cells are then expanded and infused back into the patient. Ultimately, these chimeric antigen receptor-enabled T cells, they target the patient's myeloma and lead to the myeloma cell death. What's cool about this is one thing, is that the dose really doesn't and shouldn't matter that much. Every time you inject these T cells into the patient, it should be a target-rich environment. And hence, every time a T cell sees the target, it should divide. And every time one of its children sees a target, it should divide. It's a drug that is dosed based on how many cells it encounters in the patients. And you may infuse 500,000 cells, and they may expand within the patient on encountering the patient's myeloma to 1 billion cells. And the hope is that that leads to killing of the patient's myeloma cells and remissions. When you look at BCMA, it's one of the targets on myeloma cells. And when you modify T cells by infecting them with a virus, you force them to have a BCMA receptor on their surface. Once these cells are stimulated and infected, they're infused back into the patient, as I kind of talked about. And ultimately, their myeloma cells die. This has been described in lots of different medical conferences, and it would essentially be every month I would get, there's a story in the Cleveland Plain Dealer. That's where a lot of folks in northern Ohio would show me, and they would talk about a CAR T trial that was focused on CD19, where patients had a dramatic response. And then we had ASCO, the American Society of Clinical Oncology, in 2017 in June. And then we had quite a lot of patients come and ask. Basically, at that time, there was a pharma company, Biotech, which created a CAR T trial. And what's interesting is that 94% of patients had some clinical response. And that was really all people read, nothing else. And honestly, in myeloma, why should you read anything else? You get that kind of response, hell, just don't talk anymore. Just stop there. And this makes everyone very excited. The problem is that up to this point, not as many patients have been followed for very long. And the problem with this therapy thus far is that we haven't been able to get the majority of patients responding in other trials, and they haven't been able to maintain their response. These genetically modified cells get exhausted, and they're not able to circulate around long enough to keep the patient clear of their myeloma. So while these are great results, they're very preliminary, very short-term, exceedingly low follow-up. Another trial with Blue. See, I was going to give this to Craig Cole as a gift, and he got moved. Darn it. Okay, so I'm talking too long. My apologies. I'll move it along. So, Cooper Bio has also a BCMA trial, and basically what happens in most CAR T trials, you find patients that have lots of the target, lots of BCMA on their myeloma cells. If you've seen me in Ohio, you're a patient of mine, and you have relapsed refractory myeloma, by definition, you don't have BCMA. I have no idea why this is. I assume it's a prejudice related to my University of Michigan, but something's happening. I never see patients with BCMA on their relapsed refractory myeloma, but they apparently exist in droves. And they give them lymphodepleting chemotherapy, they get the CAR Ts, and a number of these patients have had very good responses. And you see some patients have had partial response, very good partial responses, and complete responses. And this is overall very exciting at higher doses. all sorts of patients respond. But again, the problem is that these genetically modified cells do not last very long as they are exhausted by the treatment thus far. The big problem is that 25% of patients die from the treatment or wish they were dead from the treatment. Yeah. And part of the thing is when they have cytokine release syndrome, CRS. Now, in my clinic, when we say CRS, we're thinking something else. Yeah. This is cytokine release syndrome, which is essentially sepsis without an infection. So you're wicked sick. You can go to the ICU, it can be bad. But this is what happens when T cells, when the number of T cells that are genetically modified in your body go from 500,000 to 10 billion. It's a little bit stressful for your body. So these patients in both studies, this has occurred in the majority of patients who had a good response, but this is partially controllable with tocilizumab, which is a drug that can decrease some of the inflammation. Lastly, checkpoint inhibitors. Checkpoint inhibitors basically turn off an off switch, and they stop the immune system from attacking itself. Let's go over this in detail. This is, again, one of Dr. Gold's slides, and I love this sequence of slides. I thought this was the most clear explanation of checkpoint inhibition I've ever seen, so I love it. Let's go through it. So anyway, normally you have your T cells down up top, and then down at the bottom you have myeloma cells. T cells want to attack, so they head down, but they see this surface of this protein on the cell surface. They fit well together. They say, wait, we're friends. This is a good guy. And checkpoint inhibition is how you figure out self versus non-self. Not foreign. So these are overall good guys. Now, if you have T cells here and they go to a cell without the PD-L1, then hey, that could mean that the T cell can attack and destroy this cell. Again, this is how the immune system works. So in a myeloma cell, which is at the bottom, if it expresses PD-L1, then the T cell, when it attacks, says, hey, this myeloma cell is a good guy. And that's not bad, that's bad for the patient and good for the myeloma cell. Hence, this is a wolf in sheep's clothing. I love this slide. Okay, so there's all sorts of PD-1 antibodies, of which pembrolizumab and nivolumab are some of the most well-known. There's also atezolizumab and durvalumab, which are the PD-L1 antibodies. So these are all areas where when you give these antibodies, after giving them, it finds a way for the T cells to be able to attack the myeloma, see them as foreign, and ultimately lead to their death by recruiting other T cells. Okay, this was all going to be great, and then, oh darn, things didn't work out for us. So when we put together these checkpoint inhibitors with IMiDs, Revlimid or Pomalyst, the data was not clear. And CAR T cells, if you actually go back to how it all started, they got very lucky. They had some amazing responses in the first 3 patients. And if they didn't have those amazing responses, they would have run out of money and it would have been dead for a while longer. So we are able to use CAR T cells now because they had some great responses early on. These are some of the first phase 3 trials being completed in myeloma. And they're called Keynote 185 and 183. 185 looked at Keytruda or pembrolizumab being added to Revlimid and dexamethasone in the first-line setting. And this one is pembrolizumab added to pomalidomide and dexamethasone. 2 phase 3 trials. The first ones showed the side effects looked to be worse in patients with pembro. Responses were overall the same. And 19 patients died in the experimental arm with pembrolizumab added to Rev-Dex, and 9 patients in Rev and Dex alone. So, and let's go quickly through the other one, Keynote 183, pembro plus Pom and Dex. Side effects looked worse in the experimental arm. Responses looked worse in the experimental arm, and it appeared more dangerous, 29 versus 21. Now, if you're the FDA, what do? you have 29 patients in one group and 21 patients that die in the other group. Is the experimental arm worse? You know statistically, because you're the FDA, that those numbers could simply be chance. And there's a greater than 5% chance that it's probably just chance and that they're overall the same. And you look at the first one, 19 patients died versus 9 patients. Also, statistically, not different. But if you're the FDA and you're thinking, wait a minute, these are people's lives. We're not counting jelly beans. We're 19 patients versus 9. Do we let this keep going and have another patient die because we didn't put these on hold or not? So they pulled the trigger. And they stopped every checkpoint inhibitor trial that's combined with an IMiD across the country. Everyone. All the PD-1s, PD-L1s. Within a week, we got a ton of letters from the FDA saying, you must stop. And as they reformulate and figure out, wait a minute, we got to inform patients about this and make sure they adequately understand the risks and the potential for risk with these trials, and potentially change the eligibility for these trials. But this is, at the moment, on hold. To my knowledge, none of these checkpoint inhibitor trials have reopened yet, and they likely will, but with appropriate checks and balances to make sure that patients and doctors are adequately informed of this very difficult to interpret situation. Okay. Oh, by the way, if you've been through or ever gotten, I have a couple of patients on these trials who are responding, and I've kept them on the trial. One of them asked me, wait a minute, if I've gotten a PD-1 drug and then it stopped working, can I get a PD-L1 drug? And the answer is no. Okay, that's it. Thanks so much.